All right, sorry about that, everyone. Good morning. Uh, my name is Kelly Guthrie, and I am the new program coordinator for Project Echo. I have only been here a few weeks, so I'm still learning, and some things are a little bumpy still, so I do apologize. If there's anything that anyone notices during a session that I need to change or help to do better, I am all about constructive criticism. Shoot me an email. We're going to go ahead and get started for the day. We do not have a case that is being presented, but if anyone has anything that they would like to talk about now, or if we want to go through the didactic first, then anyone chime in, feel free. Does anyone have anything they would like to share with the group?
Afterward.
Okay. At this time, we're going to have Dr. Rachel Leonard go ahead and start with the didactic for the day. Let me go ahead and turn my, there we go.
It says the screen share is disabled for participants. If you just want to share and I'll have you advance it, I think that'll probably be easier.
Sorry.
That's okay.
Wrong button.
Okay, good morning. So today I'm going to talk to you about endobronchial valves. This is a newer program that we've started within the last year at WVU. So we can move on to the next slide. So today I'm going to discuss the supporting data behind endobronchial valves, review what they are, talk about their risks and benefits, cover really the appropriate patient profile that should be sent for evaluation of this, and then kind of touch briefly upon what outcomes we've had so far with our program and how you can send a referral to us if interested. So first, I'm going to start off with a case. This is a 58-year-old who we'll talk about throughout the presentation. Originally came to me in clinic in 2021, has advanced COPD and emphysema. He actually went with Dr. Toger, one of our thoracic surgeons, for a blebectomy of this bleb that was in his right middle lobe, and came to me afterwards. So after he had surgery, he was feeling much better because they removed this area of essentially air within his chest, but his PFTs at that time demonstrated an FEV1 of 22%, was still pretty dyspneic on exertion, but again, was feeling better. And then essentially I lost him to follow-up because of COVID. Several years later, he returned to me just last year with worsening dyspnea on exertion and with having frequent exacerbations in the hospital all the time. Despite appropriate therapy, his PFTs had significantly worsened over the last 2 years, and his FEV1 was down to 16%. He had a residual volume of 214%, so a lot of air trapping very big lungs, and his DLCO was down to 30% of predicted. So again, we'll touch on his case a little bit later, but endobronchial valves, what these are one-way valves that we can insert within the airways of patients who have advanced emphysema and air trapping. It's essentially a non-surgical lung volume reduction procedure. There are 2 brands within the FDA for approval, the Zephyr valve, which is on the top, and the spiration valve, which is on the bottom. We currently are placing the Zephyr valve. So that's really what I'll be talking about today. In terms of the trials for the Zephyr valve by itself, there are lots of other trials that also support the spiration valve. These are the 4 big trials. As you can see, they were followed for 6 to 12 months. They had significant improvement in lung function, exercise capacity, and improvement in quality of life as well. The lung volume or the lung function, I think, to be the most important part of this. It certainly does help patients feel less dyspneic. Why does this matter for WVU? We know that we have a huge population of COPD, especially those with emphysema. Patients with emphysema actually have an increased risk of mortality. There's a some really good studies that show the higher the bigger the lungs, the worse the outcome for these patients. They also have significant issues on quality of life. They're very dyspneic when they get around because of this air trapping as well as airflow limitation. It's also now recommended in the GOLD guidelines. So if you go to the next, this was the recommendation out of the GOLD guidelines that for patients with advanced emphysema, interventions that reduce essentially the lung volume and improve exercise tolerance are now recommended, especially the endobronchial valves with evidence A. Of course, lung volume reduction bronchoscopically is only part of a spectrum of treatment options. We do have medical management, which is the cornerstone of COPD management. We want to prevent exacerbations as best we can in order to keep lung function as good as it can be. All of these patients are sent for pulmonary rehab before we place valves. And it does help build endurance, but it is difficult for our patients to really maintain those benefits long-term. Endobronchial valves are essentially minimally invasive. We do it through a bronchoscope, and they are fully removable. So it is a reversible procedure. If I place them, the patient has a complication or doesn't feel better, we can go in and take them out. On the other kind of side of the more aggressive treatment options, there's lung volume reduction surgery, but of course, this is more evasive, but it is pretty darn effective. With all of the trials that prove that lung volume reduction surgery is good, it is very, again, patient selection is very key for those patients. And then lung transplant, unfortunately, we don't have lung transplant in the state of West Virginia. It can be very costly. It's often not an option for most of our patients due to age or even malignancy history. So who should we consider lung volume or endobronchial valves in? We should consider them in patients who have dyspnea on exertion, hyperinflation or very big lungs, and have emphysema on their CAT scans. These are the inclusion criteria, so I don't want you to focus too much on that other than they should be non-smokers. They shouldn't be significantly overweight. And their FEV1 to me should be less than 50 to be evaluated, and they should have a significant amount of air trapping on their PFTs. Contraindications. So if you can't undergo general anesthesia for any reason, that's a big contraindication for this because we do place these patients under general anesthesia. If there are any significant lung findings on their imaging, so pulmonary nodule, if you have a nodule that you're worried about cancer, if we place valves, it causes collapse of that lobe, and then I can't follow that nodule any further. If the nodule is somewhere that we're not planning on treating, that's not a reason to not place them. Or if the patient says, I'm so out of breath, I don't want this nodule worked up. If it is cancer, I don't want to know. Those patients could also get a valve with a good risk-benefit discussion with that patient. A giant bulla, so greater than a third of the hemithorax, as in the picture on the farthest right. So on that left side, the patient has this big bulla that is contraindicated for valve placement, although they are doing, a lot of the thoracic surgeons are placing valves kind of off-label for essentially a blebectomy. Or if they have significant paraseptal emphysema, which is the picture on the top. So paraseptal emphysema is when you have a lot of emphysema all around the sides. But as you can see, the lung tissue in the middle is actually pretty well preserved. And so if we place valves in that patient, we're actually taking away good lung tissue. And our goal is to take away bad lung tissue that's causing hyperinflation. There are also obviously another number of other valve contraindications. Most of these are just if the patient is too sick to undergo anesthesia. So if they've had a recent heart issue, if they've had a recent stroke, if they've been hospitalized a lot for their lungs, either with pneumonia or exacerbation. The prior lobectomy, lung volume reduction transplant, this is more considering if there's been surgery within the chest wall. And so if there's going to be a lot of scar tissue, the valves may not work, but there's a lot of newer data to say that we can actually place them and it's fine. For the gentleman that we talked about, we did place valves in him, as we'll talk about later. He had actually had that blebectomy and ended up tolerating valves on the right side later with pretty good response. If they have uncontrolled severe pulmonary hypertension, we worry about putting them under general anesthesia. And so we want to make sure that those are as controlled as we can. If they have bronchiectasis, they'll have lots of airway mucus production, and that does not work well with valves as well. And certainly heart failure, we also worry about their ability to undergo general anesthesia. So our patient gets an updated workup. He has a 6-minute walk test in clinic of 361 meters. He has an echo with kind of mild to moderate pulmonary hypertension, but below the threshold that we were worried about, with a good ejection fraction. As part of Pulmonx with the Zephyr valve, they offer this lung report where you can upload the CAT scan to their website, and it gives you a really good measure of different things that we look at for valve placement. So the black, as you can see, is the degree of emphysema. So this patient had bilateral lower lobe emphysema and was alpha-1 antitrypsin negative. The other important thing to look at is the fissural integrity, which is the number on the top. It's also represented by the lines within the pictures, and he had good fissural integrity. And so we'll talk about what that means. And then finally, as another part of the workup, we get a perfusion scan. So what we want to do is treat somewhere that has a lot of emphysema and not a lot of blood flow. And so what we're trying to do is improve his VQ match by getting rid of places that have a lot of emphysema with no blood flow. And so we're not really causing increasing hypoxemia. And as you can see with his perfusion, there's not a lot of black within the bottom. And so this shows that there's not a lot of perfusion in his lower lobes where there is all the emphysema. So he was a really good candidate moving forward for valve placement. So relying on the fissure analysis of either looking at the fissures on the CAT scan or getting the report. Unfortunately, even patients that have a 95 fissure, there's about a 15% of those patients who will be collateral ventilation positive. So what is collateral ventilation? Essentially, it's airflow across the fissures, which does occur in a good number of patients, unfortunately. These are typically done through the pores of Kohn. And what we do, so we do this big workup to see if the patient is a good candidate. And then on the day of the procedure, we do a thing called Chartis, which is this balloon assessment. So we inflate the balloon within the airway or lobe that we want to treat. We then measure the airflow that comes out at us. And what we want to see is within C and E. So you have this gradual decrease of airflow over time that goes down to 0. And so that means they're collateral ventilation negative and a good candidate for valve placement at that time. The D in the middle is unfortunately a CV positive or collateral ventilation positive. And this patient, essentially, if we put valves in them, we block the front door of airflow into the lobe, but there'd be this backdoor airflow and valves wouldn't work. And so this is kind of our final step to make sure that valves are appropriate for this patient and will actually work to treat their emphysema. So once we determine that they're CV negative, we size the valves using essentially the same deployment mechanism. There are 2 different sizes of valves, and then they come in regular and low profile. So we use these to determine what size goes into the airways. And then we place them using the same device that we use to size them. On average, patients will get 3 to 7 valves depending on where we're treating and the size of their airways. And these are what the valves look like when they're in place. And so that's a one-way valve. The airflow comes out at you, but then will not go back in. Post-procedurally, we keep them in the hospital for 3 days. The first day is in the ICU, and that's because the biggest risk of this procedure is a pneumothorax within the first 3 days. In the studies, the risk of pneumothorax was about 25%, so about a third to a fourth of these patients would get a pneumothorax. They can also develop what's called a pneumothorax ex vacuo. And so what that means is we've essentially taken away lung volume, and these patients can get really big barrel chests from all the hyperinflation. And as we collapse lung, sometimes the lung that is there can't grow to fill the space. These patients tend not to have any dyspnea associated with it. They feel good, and so we'll just watch them, and most of them do quite well. The pneumothorax is actually a pretty good indicator of success of the procedure because it means that we're getting collapse of the lung. Of course, for patient D, they had a significant pneumothorax that needed a chest tube, and that does happen in less than a third of the patients. In most cases, that heals. The patient goes home after the chest tube gets removed. If it doesn't, we remove one valve, let things heal, and then have a risk-benefit discussion about trying again. So what if we treat one of your patients, what should you expect in clinic? So the picture on the left essentially has a pre and a post. So you see the atelectasis in that left upper lobe. The diaphragm is coming up, and so it's causing essentially improvement in their dyspnea by decreasing their lung volume and allowing their diaphragm to sit and function better. Figure 3 shows kind of what we expect for complete atelectasis over time. So they have a pre-picture one day later with the valves in place, and then one a month later showing pretty darn good atelectasis in that left upper lobe. So our patient, he had valves placed. He was CV negative actually on both sides. He unfortunately coughed it out, which is another one of the major issues with valves in general, is that they're not perfect. They can migrate a little bit, they can cough it out. They can get clogged with mucus. So they're not perfect, but the revision cases can and have been done with good clinical benefit. The patient feels significantly improved. His FEV1, after only treating one side, improved from about, I think it was 17% to 29%. His DLCO went up from 30% predicted to 41% predicted. And his 6-minute walk test went from about 350 to 416, which is significantly improved. So our experience, we've probably evaluated between 20 and 30 patients, I would say, and 10 patients have undergone the procedure. We had 2 patients who were unfortunately CV positive and did not get valves. Of the remaining 8, we had 5 with complete response, as noted. If we go back, actually, I forgot to point out. So if you look on the left or the right side of the picture, the patient's left chest, you can see medially down a little bit. Those are the valves right there, and that's complete atelectasis of that left lower lobe. So he had a great clinical response, or radiographic response and clinical. All right, next slide. So we had 5 with complete response like this gentleman. We had 3 with partial but significant response where they have a decrease in volume, but for whatever reason, if the valve isn't placed 100% perfectly, or they have scar tissue, they don't get complete atelectasis of the lungs. These patients do tend to feel better, although we do think there is room for improvement. And then I had one patient most recently who had no response. So we had a CAT scan that looked exactly the same. She said she felt better. We brought her back for revision, and it looked like one of the valves had migrated a little bit distally and wasn't completely covering all of the airways of that lobe. So we were able to fix that and actually see her in clinic today to see, hopefully she has responded. So if you have questions or you're interested in sending your patients for evaluation, both myself and Dr. Al-Jaroushi both place endobronchial valves. This is our clinic and fax number, and I'd be happy to take any questions that you have.
Good morning. I'm an occupational medicine physician, but spend most of my time in the lungs right now. And I was curious about 2 separate things. I'll ask the easy one first. So if I get from the last thing, so these are radio visible. You can see them on an X-ray if they're present.
Yes.
And then so an atelectatic lobe out beyond a valve is clinical success, not a cause for concern, correct?
Correct. That's our goal, is atelectasis and collapse. So we're essentially, if we do things correctly, doing a minimally invasive lobectomy is kind of the goal.
Perfect. The second question I was curious about was, you mentioned use in emphysema, which certainly makes sense. Are there any, I know that there's a bunch of them, but are there other diseases in the COPD family that are where it's not indicated, or ones where it works especially well? other than emphysema?
You broke up in the middle there. Unfortunately, typically it's only advanced emphysema. It works really well. If they have air trapping and bad lungs without the emphysema, it just doesn't help, unfortunately, because then we're getting rid of essentially good lung tissue, if that makes sense. We're going to make their hypoxemia worse.
So for like, I was curious about the other COPD conditions. Like most of my life right now is black lung, and I don't think, it doesn't sound like this probably would not be helpful for black lung by itself, but I'm thinking chronic bronchitis, and it's that there's a whole bunch of other COPD-ish conditions, whatever COPD really is. But I'm just curious if there's any other ones besides emphysema where it seems to be especially effective, people that you might benefit from an evaluation.
Yeah, unfortunately, no. That said, it can be from multiple different causes of emphysema. So if you have a patient with alpha-1 who has a lot of emphysema, that is appropriate. Patients with only airway disease, it doesn't help because that's more of a pipe disease as opposed to kind of the tissue disease. And we need the tissue disease in order to get rid of that diseased lung to have clinical benefit.
Thank you very much.
Thank you.
Carl, my takeaway, one of my easiest takeaway is going to be atelectasis is the goal.
Correct.
I mean, that's a tiny bit of the whole, but it's an easy one to remember. And since it's counterintuitive, it's easier to remember.
No, my concern is just, I'll see somebody that has one of these, and I'll just have their X-ray, and then if I know what to recognize, I know not to worry about it as much. Now that since I know you can see the valve, that'll be the helpful part.
Sometimes when they do have complete response, it is hard to see the valves because they can actually be pulled medially, and so they're within the mediastinum on the X-ray. Certainly on the CAT scan, they're very visible, but on just a plain film, they can actually be quite difficult to see. And even the atelectasis can be difficult to see because it is complete. It kind of gets pulled towards the midline and can hide a bit.
I have a question. Well, I guess kind of question, Dr. Leonard. Of the 9 people on this call, 6 of us, to varying degrees, are here because when this echo started in about 2015 or 2016, we were and still are all involved in rural pulmonary rehabilitation clinics. And I was really struck by compared to what we see, and on this call, Brandy Bell, Terry Hauser, Catherine Warner, all are regularly doing pulmonary rehab and involved with it. And I'd be interested in their comment on this. Those 6-minute walk tests before and after look to us really good. 360 and 450 meters. I mean, when we see something above 1,000 feet, we're like, oh, that's pretty good. And my reference kind of is like pretty much all of us should easily walk over 2,000 feet, which I guess would be like around 600 or 700 meters on a 6-minute walk test. So it's striking to me how good those 6-minute walk tests were, considering the severity of their other measures.
Correct. And he was a young guy who had stayed active. And so I think he was kind of the anomaly in terms of how well his 6-minute walk test went. They have to do over 100 meters to qualify for valves. So we don't think valves are really going to help if you're really unable to do anything. And we also don't think you'll tolerate the procedure very well. And then they have to be under 500. And so if they're above 500, we think you're definitely way too well to tolerate or to benefit from valves. So you probably won't feel as good if you're already doing that well. We have had a few patients who did under 100 meters. We sent them to pulmonary rehab. And then after pulmonary rehab or in the middle of it, they did much better. And so building up that endurance is important before undergoing the anesthesia as well.
I have a few other questions, but I'm pretty sure that other people might have questions. So I'm going to wait and give somebody else a chance.
you might be good to go ahead and start asking your questions.
Okay. So one of my straight questions is, should this patient be on singular?
He does have asthma type features. And so that's why he had a significant response to essentially like perfumes and dusts and pollen. And so we often see, especially our severe COPD, kind of get these asthma type features as well.
Okay. And again, six out of the nine are involved in pulmonary rehab. And since you're kind of building a case series and for us with pulmonary rehab, one of our most objective measures is the 6-minute walk test. But performing 6-minute walk tests that are kind of with validity and reproducibility is an issue, especially if we only have like a 60-foot space that we're working in. So I'm curious how exactly you're doing yours. So I'm sure you've thought about this for validity and reproducibility. So just for the other people here who do these all the time, could you just describe how you're actually doing it and whether you just use one or use two, that sort of thing?
So we just use one, and we actually do them in clinic. So we have cones that are set up with specifically measured distance, and then we obviously count how many laps they do within the 6 minutes. But all of our clinic staff have been specifically trained in how to do the 6-minute walk tests and report them.
How long is your runway?
Oh, I don't know that number off the top of my head. I used to, but I don't know it.
Okay. Okay, great. Thanks.
And occasionally the patients do get them at our PFT lab. Sometimes that just works out better with their scheduling if they're getting the PFTs and then the 6-minute walk test. And that runway is quite a bit longer there.
Another question, and I'm trying to get some of our PR sites, pulmonary rehab sites, to weigh in here. Is what experience some of you, Terry? Let's see, Catherine, you're at Preston, right? I think Catherine Warner is at Preston with Terry Hauser. But have you guys had any experience already with patients with endobronchial? I know we have at New River. Any experience already with endobronchial tubes? Or have you even?
Dr. Doyle?
Yeah.
Catherine is with me at Preston Memorial. We did have a patient that completed pulmonary rehab. And after his completion with pulmonary rehab, he was going to see Dr. Leonard for a valve. We have not touched base with him since, if the procedure was successful or, if he was able to, whatever, since he's graduated. But it was kind of, when he told us about it, we were like, what are you talking about? Because we had never heard of this. So we were like, we think you're confused, but he wasn't confused. We were confused. And we learned more about this at our West Virginia ACVPR conference a couple weeks ago. Actually, last week or week before, we learned more about these valves. So, it's just something new that we had not heard of. And when he said he was going to undergo this and it's supposed to help him, we were very thrown off by that. So we really need to touch base with him and see, how he's doing and so forth, to see if it was, actually beneficial for him.
Great. Well, in a second, I'm gonna transition and ask us to do introductions, Kelly, since for some of us, it's the first time we've gotten to meet you. And be good for you to, see, because some of the people here are regulars. There's probably a population of about 30 to 40 people who have ever attended one of these. Over the past 2 years, the Division of Occupational Medicine there at WVU has become a really important part of these, because a number of the residents have been doing the presentations. And there's some of our hub faculty who usually attend, like Dr. Stansbury and David Weissman, who aren't here today. But so I would like to just ask that we just do some real quick introductions. My name is Dan Doyle. I'm a retired family physician from Southern West Virginia, Fayette County, and have been involved with our pulmonary rehab network, which is called Appalachian Pulmonary Health Project and Grace Ann Dorney Pulmonary Rehab Centers since 2013. And this has been a really important monthly, first it was twice a month, now we're monthly opportunity for us to kind of just get together and compare cases and learn new things.
Thank you for sharing, and I do apologize that I did not start out with having everyone do introductions. So I am Kelly Guthrie. I'm actually from Preston County, where Terry and Catherine are from. I have I received a bachelor's degree in public education and a master's in business communications. I worked in high school, public school for a year, and it was a little traumatizing, but I survived. And then I worked for the college, and now I'm here. Just sitting in today, I think it's amazing what you guys are doing and everything that you guys are sharing with one another to be able to outreach the information that you guys are providing to be able to help others. All right, who would like to go next? Rachel, do you want to like reintroduce yourself, or are you okay?
I'm Rachel Leonard. I'm one of the associate professors at WVU. I've actually been in West Virginia now for over a decade. I did both my residency and fellowship here at WVU, and got promoted last year to associate professor. So I'm just really excited to offer all the things to our COPD patients, and hopefully get our patients feeling better.
All right, awesome. Thank you for sharing. Catherine, are you able to join in?
Yes, ma'am. I can do
right.
microphone. My name's Catherine Warner. I'm a nurse at Preston Memorial Hospital Pulmonary Rehab. And I've been doing this since I think January or February, but very educational. I learned a lot because I'm new to the pulmonary rehab world. I was a medical ICU nurse for 12 years before I switched to outpatient. So this has been very informative opportunity. Thank you.
All right, I'm going to go ahead and read for Brandy, if that's okay. Brandy Bell said that she doesn't have them like this morning. I don't know all the acronyms. I do
She's
apologize.
a respiratory therapist, and I think certified in PFTs. My guess.
Thank you. And she works at Lincoln Primary Care in Lincoln County at Grace Ann Dorney Pulmonary Rehab. Thank you for sharing that in the group. All right, next, Terry, would you like to go ahead and introduce yourself?
I'm Terry Hauser, and I work out of Preston Memorial Grace and Dorney Pulmonary Rehab Center here in Preston County. I'm the manager over cardiac and pulmonary rehab here.
Thank you for joining us. Carl?
Sure, there we go. I'm Carl Ward, so I'm 26, on my way out of Preston Memorial in a place where cell phones don't always want to play. Anyway, occupational medicine physician based out of Morgantown, but I also see patients out here at Preston and also down at Cavernary Cup. And these people, when we started all this work, you got involved. This was set up where it was twice a month sessions, one really focused on black lung and one focused on pulmonary rehab, and with a lot of outside speakers in both groups. There's that community. I think we've lost the black lung people because we haven't done a black lung related topic forever. But you're talking about claims management and stuff like that. It's not necessarily what you think of as pulmonary diseases, but how you get people benefits and things like that. So it was a little bit different focus in the past. Anyway, so that's my story from out here in the wilds of Preston County.
You had kind of cut out for some of it, but we heard the latter end of what you were saying. Thank you for sharing with the group. Be careful on your travels. Next, we have Is it Martin?
Hi, Martine Eon. So I'm in Portland, Maine at Maine Health. My role here as a clinical specialist for lung health, we have a 9-hospital system. And so I do education. I've worked in pulmonary rehab. I create provider tools to kind of like condense, like for instance, goal guidelines to condense that into a couple pages if that's possible. I also create patient education materials. So every day is a little bit different. That's it. Thank you. I really enjoy these. Any opportunity to improve kind of my breadth of the new technologies and the new offerings for patients is really important. And in Maine, we don't have a COPD echo, so I really appreciate joining this one. Thank you. And your talk was fabulous, Dr. Leonard.
Thank you.
Thank you for joining us. Lastly, can we have Diana?
Yes, good morning. My name is Diana Carpenter. I'm a project manager for the PA Rural Health Model, which is part of the RHRC, Rural Health Redesign Center in Harrisburg, Pennsylvania. We try to just link up with the ARC program just to see what's going on and what's out there for people, and just like to stay abreast of what's going on in the community. So I appreciate you all letting me join.
Thank you for joining, and thank you everyone for the introduction. Sorry that I didn't do that first. I promise I'll get better over time. If there is anyone that ever has a specific topic that they would like covered, please feel free to reach out to me. The email is fine, or if you want to be able to share a case with the group prior to the didactic, I can also get that set up for you. Does anyone else have any more questions that they would like to share with the groups, get some input from Dr. Leonard?
Okay, I'll try to be brief. Okay, it's 8:40. I know you guys want to get off. Dr. Leonard's got to go to the clinic. Carl's on the way to Preston. Carl, if you can still hear us, you had mentioned black lung, and I wanted to just make sure we announce here. Can you say something about the state black lung clinic meeting? And if you're breaking up, I'll try to do it for you. But if you can do it, go ahead.
Well, I'll try. So the state actually and national, because we're hosting the national black lung meeting, will be next. It's the first week in June. I think starts on the 2nd. It's Thursday. It's Tuesday, Wednesday, Thursday, and half the day Friday down at Pipestem Resort. It's got, because it's the national meeting, it's at times separate tracks for benefits people, medical people, and legal people. So please, if you're interested in black lung or black lung related topics, that is the place to be to find out what's really going on, both in West Virginia and this year in the nation. Did I miss anything that you want to mention?
I don't think so, other than it's not uncommon to have people from other countries of the world as well. It's become really the premier meeting definitely in North America for black lung, but a number of people are involved in places like Australia and South Africa and Europe. So it's a super meeting in a super place, and this is short notice for some of you, but think about next year because it's almost always at Pipestem in June. Oh, and then, okay, I would like to, Martine, I know you've been here before, and thanks for being here again. And Brandy, what Martine said about developing education materials matches up with what we're talking about in our RT group here right now about wanting to develop educational materials. And I think you might have even been one of the people that volunteered to work on that. Martine, Martine, can you just give us your email and cell phone number if you don't mind right now? And I'm going to write it down. Brandy, write it down, because it would be really good to get in touch with you, because we're trying to develop updated network pulmonary rehab education modules.
I can put it in the chat. It might be easier.
Okay, that'd be great. But before we sign off, let's make sure we get a chance to copy it down. And then I have a question, and it related to what Carl said about COPD-ish, and you know, Dr. Leonard, I saw you kind of smile when you said that, and this could be a long discussion, but that's not my intention, but it's something I hope that we'll come back to in these sessions. And that is, does anybody feel there's any hope of transitioning the term COPD from referring to all chronic lung disease to in our lifetime to just to any hope for that term to become specific instead of an all-encompassing term, especially since a lot of the national statistics are still being reported as COPD when they include all kinds of other chronic lung diseases. A lot of work has, in this echo, a lot of work has gone into upgrading our knowledge about interstitial lung diseases over the last few years. And I'm trying to remember the person there who's done fabulous talks for us about that, about differential diagnosis. But anyway, the question is, are we just stuck with COPD as the catch-all term for chronic respiratory disease and just give up and accept it? Or is there any hope? Or is it worth making an effort to educate ourselves and even patients and consultants that that's going away, that that's changing?
Well, I'll give you Carl's opinion. We need a phrase for crappy lungs that I don't know why. And we've just, or in my little world of black lung, people have not yet been approved for benefits. Because one of the things you have to understand, if you kind of think about just from a providing care for the patient perspective, is if I call it COPD, I can prescribe, appropriate treatment, bronchodilators or whatever, and the insurance companies pay for it. They'll pay for the office visit and they'll pay for their treatment. If I call it black lung and they've not been approved for benefits, nobody's going to pay for their care. We just need to, I personally would fully favor that we would develop a new diagnostic code for crappy lung NOS, and then you use that instead. But I don't know that that's going to fly with the people that make up diagnostic codes. Does that make sense?
Unfortunately, yes. How about you, Dr.
I'm actually happy with COPD because it's not a diagnosis. It's not a pathology. Let me say it that way. And it is, emphysema is a pathology. Chronic bronchitis is a pathology. The COPD is I don't know what you call it, a term of art for crappy lungs without having to write crappy lungs in somebody's chart, or breathlessness of unknown etiology. Somehow I agree we let people get lazy and use COPD as a diagnosis without testing. But I don't know what the right step forward is. I'd rather, from a clinical care perspective, I'd rather that you had a way to treat people with crappy lungs that don't have access to medical care enough to get a full diagnostic workup, than to deny them care because we decide COPD is not. We don't have a phrase for them that'll allow them to get care. I don't know. This is a catch-22. I just prefer one of my personal rules is beyond the emergent need or initial need for treatment, I don't use the term COPD. I never diagnose that because I don't even know what it is. We've got the GOLD criteria, which isn't diagnostic of anything, and they tell you that in their own criteria that this is for treatment, not for diagnosis. And so I never diagnose that because I don't know what it is.
Yeah, one of the issues is trying to get problem lists in the electronic health record internally, like within our primary care centers, to be a little more accurate. I mean, probably everybody here has experienced, problem lists are kind of a mess. And trying to, and the more things that are on it, then the less any one individually seems to weigh. So trying to, and we're all doing pulmonary function tests, and we're seeing people with crappy lungs who don't have obstruction. But I'll pass it to you, Dr. Leonard.
Yeah, I think it's really tricky. I mean, COPD is this umbrella term that's encompassing a lot of different types of diseases, and I don't think it's fair to try and clump everybody together I mean, COPD really should be airway obstruction with a ratio less than the lower limit of normal for a patient. But even with the new ERS came out with a new way to read PFTs that is very different. And I don't know how that's even going to change the landscape of things. But what I'm learning is that, you know, we're starting to look at the different phenotypes of COPD, the chronic bronchitis and the emphysema, and treat them separately. And so it's really a patient specific treatment nowadays, where, you know, if they have a lot of chronic bronchitis and a lot of exacerbations, and we check a phenotype of eosinophilia, then we can start them on a biologic and they do better. So we're trying to figure out what's driving their disease. Is it airway inflammation and ongoing issues with that? And should we be really starting something different, or is it really more emphysema and air trapping and breathlessness, and they would benefit from surgery or, you know, valve therapy? And so same with asthma, where we're kind of looking more at phenotypes and trying to personalize asthma treatment based on, are they eosinophilic or neutrophilic? We're starting to do the same thing with COPD as well.
Kelly, I promise not to talk anymore. I'm passing it back to you to wrap us up.
You're completely fine. Thank you for everything. You definitely helped make the meeting run a little smoother, so I appreciate that. I want to thank you all for your time and for joining us this morning. Our next session will be June 18th. We're going to have Dr. Sharma talking about sleep disparities. Sorry, sleep disparities. So thank you everyone for joining, and I hope you have a great Monday and have a great week.
Thanks,
Thank
Dr.
you.
Leonard. That was great.
Thank you,
Yes,
guys.
thank you.